Hey, this is Dr. Scott Worden, the TOS guy, and today we have one of our most viewed contributors, Steve Taljakowski, the famous physical therapist in California who has taken over the Peter Edgelow program. Today's talk is about regaining control with physical therapy and the INVEST program. Steve, it's great to have you back, and I look forward to your talk as usual.
Hey, thanks, Scott. Thanks for having me back. It's been a while since I've had my last presentation, but I want to thank the viewers who have reached out to our group. And locally, I've had some people who've seen the videos and have come by the clinic, and I've had some people that have contacted me by email, and I've been able to do some consulting and sessions online. So I appreciate that, and I'm learning how to do this. It used to be just I'd be in the clinic and I'd get referrals from physicians, and now things are changing. So I really appreciate the support. I've been a PT for 28 years now, and I've been seeing thoracic outlet patients for, I think, almost 24 years of that. And the first 14 years, I worked with Peter Edgelow in the same clinic. So that's where I got my experience treating thoracic outlet patients. But being a therapist, I've seen a lot of different patients. I don't just treat thoracic outlet. I've seen spine patients. I'm a McKenzie certified therapist, and but treated everything from kind of head to toe. And some injuries are pretty straightforward. You have a knee injury or a shoulder injury. Sometimes it's a sprain or a strain, and you take time, do some exercises, and recover. And if it's even a little bit worse, and maybe you need to see a surgeon. Generally, those outcomes are pretty good. But what we're talking about is thoracic outlet, which kind of falls into that kind of chronic pain category. And there are other injuries that are also chronic pain. And I don't want to characterize like which problem is worse than the other from what I've seen. But in my experience, thoracic outlet can be a pretty devastating injury. Now, of course, it ranges from mild to severe, so there is a spectrum there. But I'm just going to share some of the experiences that people have told me, described to me over these last 24 years. And for a lot of people, it's just that
Hey, Steve, we're actually not getting your audio or video right now.
Can be agonizing. If you're lucky enough to be able to still be working, that's about all you've got is the energy to go to work. Other people have reduced their hours, and in some cases, a lot of folks have just been unable to work. And if you're unable to work, then it means you're the person home. And that means if you have children, you're taking them to school. Well, sometimes just driving 10, 15 minutes is more than enough or too much. Any trips longer than that, you usually need help, a family member or a friend. Making breakfast is just the simple basics. Cleaning the house, doing things as simple as, sweeping the floor, washing dishes, cleaning the bathroom. A lot of those things are just too much, and they just get let go. They don't happen. And then there's the sort of daily fatigue from not sleeping well enough and taking naps that don't really restore anything. And then dinner comes, and who wants to make dinner? It's hard to cut vegetables, lift up a pan. So that's usually, again, simple food delivery or have somebody else do it. Then the evening comes, and check some emails, maybe watch TV, and even that's hard. Sometimes being on a computer for more than 5 minutes is too much. And then the day starts over again. And I didn't even mention the impact on people's relationships with their partners, their family, their friend. And then just to getting the feeling after a while, after 6 months, a year or longer, people wondering like, well, do you still have this thing? Like, what's going on? You know, and all the while it seems to be getting worse. So the reason I'm bringing this up is what I feel has happened is that TOS has taken control. It's taken control of people's lives. Again, it's a spectrum, but in some cases it's taken complete control. And so my talk today is to talk about some of the principles of how to regain control with the INVEST program. That's the Agilo Neurovascular Entrapment Self-Treatment Program. And of course, that falls under the physical therapy category. So I'm going to start with the presentation. So if Herb can start that. So these are just some basic concepts. These are not all the concepts. They're not. They don't encompass everything. But I'm going to read through a few of these things, and then with each of these categories, I have a slide or two that's going to describe them in more detail. But first, it's important that people understand the anatomy of TOS and what's happening. Next is to relax, open, and calm. That's going to be the mantra that people will, I hope, will follow. Avoid stretching and strengthening exercises that aggravate your condition. You need to learn how to measure objectively your body's response to exercise and activity. You need to simplify the treatment approach. You must become the patient and the therapist at the same time, and just to have a realistic progression and expectation of what the program's going to do. If you've seen any of these videos, you've also noticed that there's been a lot of talk about anatomy. So I'm not going to go into a lot of detail today, but we have to understand if you have thoracic outlet, something is going on between the scalene muscles and the pec minor and underneath the clavicle or collarbone. There's compression of the nerves or the vascular system. I'm going to be talking more about the neurogenic version of thoracic outlet. It's primarily the biggest form, but when you're treating thoracic outlet, you have to look at those structures and how to influence them. Everything else, I think, is secondary. It doesn't mean you can't have a problem in your neck or your shoulder, but what it means is thoracic outlet, we have to address that area. If you look at the picture on the right, that's more of a picture just of the scalenes in the first rib, and you can see how the brachial plexus runs through that space. That's a scalene triangle. And understanding that scalenes control both neck movement and rib elevation. So the two primary components of exercise and treatment is going to focus on posture and breathing. But also remember, a lot of people have a narrow space and don't have thoracic outlet. What's wrong is that the nervous system is irritated. So there has to be a component of the program at the beginning to address irritability of the nerve. So that comes back to, oops, let's get this out of the way. Relax, open, and calm. First day I'd see my patients, that's the approach we're going to take. So what we need to do is the relaxed part is to relax the muscles in the thoracic outlet area. And that's through the practice of diaphragmatic breathing. If we breathe from the diaphragm, we're not going to breathe from the upper chest muscles, including the scalenes. We also have to relax the muscles in the thoracic outlet through postural awareness. We have to open up the space through posture. We open up the space, so we're like relaxing the muscles, then we're opening the space through postural correction, scaling, and other muscle relaxation. We also got to mobilize the first rib and the thoracic spine and the lumbar spine in order to maintain or to achieve a more upright posture. If your thoracic spine is stiff, if the low back is stiff, it's going to be hard to get an erect posture and a more neutral posture. I would say, though, is that the mobilization of the first rib and thoracic spine and lumbar spine occur later. What has to happen first is we need to calm the nerves. Nerves can't be calmed down though until the compression is stopped. So we have to learn how to open the space, either through muscle relaxation, postural alignment, and over time, the nerves will become relaxed and less symptomatic. The next point is to avoid exercises that aggravate your symptoms. Exercises that produce more compression will aggravate your symptoms and must be avoided. That can mean anything. I have a lot of patients who come in and they're doing things, let's say yoga, Pilates, they're still doing strength training. They might be doing core exercises, some kind of more strenuous, aerobic exercise, such as, spin bike, biking, swimming. If an exercise aggravates your symptom, you have to stop the exercise. Now, when people hear that, they get concerned because they feel like things like yoga, which I love. I think yoga is an amazing exercise. It teaches posture, awareness, breathing, but there are too many movements in yoga that could potentially aggravate thoracic outlet. Same with the other exercises I mentioned, Pilates, using the reformer, using a spin bike. If the exercise aggravates your symptoms, you have to stop. There is no pain, no gain in INVEST program. Pain creates more tension, it creates more irritability of the nerve, and it continues the problem. I'm not saying that you would have to stop yoga forever or whatever exercise you like to do. You need to stop, calm things down, and then you can start to bring it back in. The goal is to do more. The goal is to return back to doing all those exercises and fitness activities that you love, but we got to take care of the thoracic outlet. So the more irritated a nerve is, the less it takes to irritate that nerve. So as people get more and more irritated, the rules change, the bar becomes lower. So it gets to a point where just sitting, using a computer, just breathing can aggravate your condition. So we need to stop that, calm down the nerve, and then start to, over time, as things get better, resume your activities. Weakness and fatigue should be considered a symptom of TOS, not the cause. So when people feel weakness in their arm, the answer is not to strengthen it. I want you to remember what I call the tourniquet concept. I give this example to everybody in the clinic the first day. If you know what a tourniquet is, it would be a strap that you'd wrap around your arms to cut off circulation. If you're not sure what that is, then think about a blood pressure cuff. You can imagine pumping up a blood pressure cuff, and it gets to that point where it gets tighter and tighter, and you're thinking, how much more can I take of this? Well, just imagine that we stop right there and keep the pressure on. Now, if you had a tourniquet and it was completely tight, obviously over a short period of time, you'd have significant problems. But I'm talking about just this idea of something compressing your arm and squeezing it and not stopping. So if I think of the tourniquet blood pressure cuff idea, if you kept that blood pressure or tourniquet on your arm for a while, I'll ask patients, like, what do you think you'd feel? And I made a list of things here: pain, numbness, tingling, burning, aching, soreness, weakness, loss of range of motion, coldness, color changes, swelling. And then I ask patients, do any of these symptoms sound familiar? And some people will say, a few of them. And some people will say all of them. Because really what's happening, that tourniquet or that blood pressure cuff is cutting off circulation, is compressing the nerve. And if you keep that compression on long enough, you'll get those symptoms. So I'm going to look at those symptoms in another way, though. We're going to put them down as either being subjective or objective, signs and symptoms. So under the subjective category are things like the pain, numbness, tingling, burning, aching, soreness, the exact same things I showed you before. But Things like weakness, loss of range of motion, coldness, color changes, and swelling are objective measures. So what's the difference? Subjective symptoms are things that you describe. I have pain. My pain's a 7 out of 10. My hand feels numb, feels aching. There's no way that I can measure pain on a scale that is consistent between patients. It's just your subjective interpretation of what it feels like. On the other hand, I can measure weakness. I can measure loss of range of motion through angles and degrees. I can measure temperature of your hands by measuring with a thermometer. I can see color changes. I can see swelling. So objective measurements are the things that we can see. If we can see something, we can see the change in it. So objective measurements are a more reliable and reproducible method of assessing improvement or aggravation. Things that we use in the clinic are things that the patient can do themselves. They can measure arm elevation, range of motion. I can show you later. They can do, or you can raise your arm like this, you know, and as soon as you start feeling that nerve tension, that's how far you can raise your arm. When we do something later, we're going to see if that's higher or lower. Same with neck range of motion. Typically, when I turn away, let's say my left arm is the involved arm, I'm going to feel pain or tension there because as I'm turning my head, I'm creating more tension on the brachial plexus. I can check hand temperature. We measure index finger and pinky finger. Index finger would be more the median nerve. But pinky would be the ulnar nerve. Typically with people with thoracic outlet, their pinky is colder than their index finger, or their involved hand would be colder than their uninvolved hand if they have an uninvolved hand. We can do an exercise and see if that temperature changes. We can also do grip strength and thumb strength. Thumb strength is a thing that we introduce in the INVEST program. I can't get into detail right here, but grip strength could be as simple as doing a grip dynamometer. Remember, objective measurements are important. If you had high blood pressure, the doctor doesn't ask you how you feel as far as your blood pressure is going today. They would take your blood pressure. You would not know necessarily if you have high blood pressure or not. If it's really high, you might have symptoms. But if it's high, you could feel fine. So you track the movement of that blood pressure through medication and diet and exercise. And as that blood pressure goes down objectively, then you start to feel better. Next thing is to simplify treatment. A lot of people that I've seen have seen people before me, and they've been dealing with it for a long time. So as a result, people pick up a number of treatment ideas. So by the time I see them, it's a kind of mix of everything. It's some exercises they learn from one therapist or some exercises they learn from somebody else. They're doing something their trainer taught them to do. And what they're looking for is an answer. And what they found is just kind of a mix of treatment ideas that don't have focus. So we have to make an honest and informed assessment of those treatment approaches. Are those treatments helping or hurting you? Are they aggravating your symptoms or are they actually getting better? If they're aggravating them, we need to let them go for now. You must become the therapist as well as the patient, as you are responsible for the outcome of your treatment plan and program. People are going to give you information. They're going to give you everything that they know. It's going to be up to you to decide, based on these principles that I've just mentioned, is that exercise or is that treatment plan helping me? I said it more than once. No pain, no gain does not work. If a treatment or an exercise causes pain in thoracic outlet, it's going to make it worse. It's just the indication that you're irritating the nerve more. There are some cases maybe in the spine where if you did some stretches, it might be sore. We're not talking about that. That's joint pain. That's something else. We're talking about nerve pain. Lastly, I think we need to have realistic expectations as to what the program's going to be. Recovery takes time. Calming the nervous system takes time. I had a conversation with someone today who's a musician, and we talked about just the expectation of learning an instrument. You wouldn't learn to play an instrument in a month or two. It can take months and years to become very good at it. I'm going to tell you, getting over thoracic outlet, learning these exercises, learning how to control your posture and breathing is not easier than learning an instrument. I'm not saying it's going to take multiple years to get better, but it's going to take time to improve. And it's not going to be a week or two or a month or two. In the program, though, a person can and should see immediate objective improvements. The problem is at first those improvements won't last. So what happens is people get excited. Oh, that first visit, we see somebody, we do a few things. Oh, I feel better. Then the next day or maybe 10 minutes from now, your symptoms return. That's normal. All it proved is that you have the ability to control your condition. What we have to do is maintain that control and understand that everything you're doing through the day either hurts or helps. So if you understand what hurts or helps, you can make the change. So changing movement patterns and habits takes time. It's like learning an instrument, learning a new language, learning any skill. It doesn't happen overnight. We're too focused on the quick fix. Learn a language in 3 months. Do something quickly. This doesn't work that way. You can only add an exercise when you can prove that the exercise will not aggravate your TOS. And don't become discouraged by slow progress, but focus on the immediate objective improvements. This is all about what's happening right now at this moment. That's the only thing we have control over. We can't control the past. It's already happened. You have to learn from that. And thinking about the future only sets up stress and anxiety because the future doesn't look that bright for a lot of people. So being fearful of the future, being nervous about the future or anxious will only lead to be more stress. Okay? If one can make consistent objective improvements, then they will eventually make an overall improvement and their thoracic outlet will get better. So we focus on the objective improvements. If an exercise makes it worse, we have to stop. We have to see that everything we do is either going to help or not make it worse. If something aggravates it, we have to figure out a way to remove that when you can. And obviously the thing that seems to be the easiest thing to remove are things that are unnecessary, like unnecessary exercises. Okay? So whether you think you can or you think you can't, you're right. And unfortunately, this comes from Henry Ford, who I don't particularly like, but I think it's a good phrase. So I'm pretty much done with what I was going to say as far as a presentation. I don't know, Scott, or if you have any comments.
That's great. Thank you, Steve. Always enjoy watching your talks because you organize them from the top down through large concepts to details. So I appreciate that. For somebody who's not a physical therapist, it's great to start learning from somebody like you through that method. And I also love that Henry Ford quote. That's really good.
Yeah. Well, it is about the details. It's the small things that really make a difference. I was going to say something, I forgot to say it earlier, but it's this idea. I think people want exercises. They even want the INVEST program. They say, I want to learn the program. But there's so many concepts and sort of fine tuning that has to happen. And I don't mean that to be overwhelming. It's just that it needs to have an understanding of principles and concepts and be aware of this no pain, no gain rule and this idea of being able to self-assess. The exercises are just the ingredients. I make an analogy of like, what is bread? I mean, bread is flour, water, yeast, and salt. You put it in the right person's hands, and they can make the most amazing baguette or pizza crust you've ever had in your life, and somebody else can make Wonder Bread. It's
Having
the
been the
same
owner of a bread
ingredients.
machine, I know how hard it is. It's
Yeah.
deceptively hard.
So the ingredients are there, but it takes skill to put them together into a meaningful way. And I'm not saying I'm the only person that can help, but I think, matter of fact, I know I'm not. But if a person has these concepts, they can begin to sort of become critical and look at the fine details and look at the small things that will enable them to gain control, because it's all about gaining control. When you've lost control of something, it's an emotion. It's devastating emotionally.
There's a Japanese proverb that says, fall 7 times, stand 8 times.
Yeah, I like that.
So I have a few questions that you raised in my mind I'd like to ask. I was actually taking notes as you were talking. So let me hit a couple of these. First is, are there medications that you believe patients take, either oral medications or injections, that help your program, that help the patients get through the steps?
I mean, I'm not the one who, I'm not involved in the medication decision or the injection. I mean, I've certainly seen people that have, they seem to do better when they're on certain medications. I think the frustration with that is that people feel like if they stop taking it, they're going to get worse again. So they feel kind of trapped in this, drug cycle where, or the same thing, I'll see someone get a Botox injection and then, there's this feeling that over time it's going to wear off and then they're going to be back to where they started.
Sure.
And then, but I'm just thinking, well, this is a moment in the time that Botox injection is going to last, that we got to double down on the program. That are really, now it gives you this sense of like, now I'm not in, because people can be in a lot of pain, and it's hard to get into a program where you're exercising 4 times a day, maybe walking several times a day, even though the exercises should always be pain-free. But it gives, I think, by having these, some medication or maybe the Botox injection, gives you that window of time to really work on the program. So I think it's a mistake to get the injection and then come back 3 months later and say, well, it didn't work, I want to start therapy now. And I'm saying, well, we should have been working with therapy at the same time. And the same with any kind of medication is that if the medication can control your symptoms, then if you feel better enough, then we can progress the program maybe quicker. But the goal is obviously to get off of everything. And I don't think the goal, though, is to get off the program. I think the goal is to learn principles that you will carry forward the rest of your life.
Right. Many people who go through conservative therapy and do well understand in the future, I'm preaching to the choir, but when they get a flare, they recognize it earlier and they manage it better. Is that a fair assumption?
Yeah, I think so. Yeah, I think flare-ups happen. It's how you deal with it. Can you stop, like you said, can you stop it sooner? And the fact that you know how to deal with flare-up gives you control as to, okay, I did something I shouldn't have done. I got a flare-up, and hey, I know how to handle it. And emotionally, that's a huge step, because I think people feel trapped. And when you have these flare-ups for doing sometimes small things, it feels there's a bit of hopelessness, and at least in some patients that I see. So the fact that you feel, I keep saying about gaining control, if you have a flare-up, I know what to do. It's going to take a few days, maybe longer, maybe less, but if I can do that, anger or fear or whatever a person has maybe will be controlled better. And anger, fear, whatever you want to say, it has a huge impact on nervous system injuries and the whole explain pain concept of just ramping up the sensitivity of the nervous system when you're stressed is it's a real thing.
Right. The nervous system has an afferent limb, an outgoing limb that goes to all these receptors in the body and says, calm down. And many people believe that in depression, for example, chronic pain, that part of the nervous system just fades, that it doesn't provide this modulating effect, which may explain why some chronic pain patients get better with antidepressants. So, as we know, some medications work better in synergy. For example, there have been some papers showing that people who take cannabinoids, medical marijuana, can decrease their dose of opioids or morphine-like drugs and get just as good or better pain relief by mixing small doses of the two drugs than a high dose of either drug alone. Would that be a fair analogy to say when a patient gets medicated, like a nerve stabilizing agent or Botox, and they combine it with your program, that there's synergy, that window you talk about?
I would hope so. I mean, because the intention of the program at the beginning, especially, is to work on relaxing things, opening up spaces, calming things down, calming the nervous system down, so that the focus is sort of matches what I think what some of these medications are doing. So you're coming at it from both an external source, but you're also looking at it internally. And I still feel that the internal part is critical because everything's going to wear off at some point.
Right.
And then how do you learn that you can do some of these same calming down, relaxation mechanisms naturally? It's just that it takes time, and I think and if you're flared up, it seems like the improvements are small. So that's getting the realistic expectation about not expecting the improvement to be immediate, or if it doesn't work, in a week or two or a month, I'm going to give up and try something else, because there's a lot of options out there.
Right.
I'm not the only one, obviously.
I'm going to intersperse with some patient questions besides the ones that I ask you, if that's okay. Well, I was going to ask a different one. Here's this one. My TOS diagnosis is relatively new, 6 months. Is it realistic to think that I could be back to normal activity within 6 months? Lots of yoga and cycling. And this is from Haley in Birmingham, England, UK.
I mean, I would say that the longer TOS exists, probably the longer it takes to recover. I don't necessarily think there's a 1-to-1 ratio in that where, hey, if you had it for 3 years, it's going to take 3 years to get better. I would say 6 months is pretty quick as far as a full recovery, and again, full recovery is a slippery question. I'm sure if a person said, hey, 6 months from now, I feel pretty good, and I can bike, but maybe not as long as I used to be able to bike, or hey, I can do yoga, but there's a couple moves that maybe are still a problem. I would hope that a person wouldn't be disappointed in improvement, considering that 6 months ago, they may not have been able to do any of those things. So I think people want this end result. I mean, people ask me all the time, they want to know what's going to happen at the end. I'm saying what's going to happen in the next 10 minutes. If you can feel a little better in the next 10 minutes or start getting this understanding, the rest will, I think, eventually sort of take care of itself. And also it goes back to the idea of anatomically what's going on. You might find out you have thoracic outlet because there are some anatomical anomalies that you didn't know about yet. So how severe those are will kind of determine, in some cases, how quick the recovery is. There's some pretty severe anatomical anomalies that people have done really well after. So I don't want to sound like because MRI shows something that's going to be the determination solely of whether you'll get better. But it does sometimes change the timeline, and it also maybe would give if a person was getting better and plateaued, there maybe those anatomical anomalies could explain why.
Mm-hmm. I'd like to add into that thought because I get patients who ask me how much the MRI determines what's going on. And let's face it, people who are born with muscular anomalies, they've had it their whole life. So it's really the superimposed process, the inflammation, the overuse. So using a clinician like you, a person with judgment, assessing the patient's symptoms, the signs, their posture, etc., is obviously a large part of the equation besides the imaging. Next question we have, 330K dog. I don't know if that's somebody who's run 330Ks, but how is your treatment plan different in a patient who is pre-surgical versus post-surgical?
A lot of the concepts are exactly the same. This idea of don't aggravate things, work on posture. Obviously, if you remove the scalenes and that first rib, some of the first rib mobilization is going to be unnecessary. The diaphragm breathing will still be an issue. Will still be you'll still tell people to breathe through the diaphragm because they have another side. And I have a patient I just saw recently who has had surgery on the right. Left is doing pretty well, but we don't know. I mean, so you're doing a program not only to sort of help the right, but sort of save the left. But I would say that there's probably a little bit more of pushing things like range of motion quicker than if you would if they had TOS. Because a lot of times if they elevate the arm, they're compressing the space. A rib removed and the scalenes removed. They might have some pain, but that could be surgical pain, still some swelling. So I'm probably more. I want that to calm down, but I don't want them to develop scar tissue. You don't want them to develop stiffness in their shoulder. So you're going to progress that part quicker because in some ways the compression is probably more from swelling and irritation, not from mechanical compression. So I would say, you can be a little bit more, you can move things along quicker. You probably have to move things along quicker because you don't, because you need to sort of respect that healing process and the scar tissue development.
So you decrease the risk of scar tissue and you help the nerves glide more by earlier mobilization.
Right.
Mobility. Okay. Range of motion.
Right. Yes.
So a question I had written down, which this brings up, and thank you for the question on that. Can you tell us a little bit about first rib mobilization?
Well, there's, the first rib, obviously, I don't know what people, it's funny, I'll show people a first rib mobilization exercise. It's one of the first, it's the fourth exercise in the INVEST program. And we have a ball and stick and it goes right up here. And of course, the first reaction is like, I didn't know my first rib was there. And then we have a skeleton in the clinic and you look at it and you go, oh yeah, I guess I didn't even think about it. So the first rib is going to be mobilized from on top because of the direction it's facing, and there's nothing on top of it. So what we're doing is we're using a ball and stick to I don't want to get too much into detail, but you're kind of lying down, the stick is against the wall, the ball's pushing against the first rib. And then we're doing a breathing exercise with a pelvic mobility. And then as you're exhaling, the way the body moves is the pressure on the ball increases, which is perfect because when you're exhaling, the scalene should be relaxed. So we're mobilizing the rib during the exhale. So the idea would be is and that rib is just slightly elevated in part from just a postural position, from a dominant upper chest breathing, and just probably from scaling, guarding, and tightness that just elevates the rib. I'm sure we're only talking a few millimeters of difference, but like anything, a couple millimeters can be the difference between no pain and excruciating pain.
So for viewers, the first rib is C-shaped, and where my thumbs are, where it attaches to the cervical spine, there's a joint, and so it can swivel. I'm exaggerating, but it can swivel up and down like this. So Steve, what you're talking about is the rib cage essentially can be elevated because the ribs are all tied together by the intercostals. Right. And that means if the first rib is up, it's probably because the scalenes are tight. The rib can't drop until the scalenes relax. Is that a fair statement?
It would be a fair statement, and I want to make clear when you, because people ask me, well, I want to stretch my scalenes. And I would say, no, you need to relax your scalenes. So everybody wants to massage things. The problem is it would be really hard to massage your scalene and not put pressure directly on the brachial plexus. So I'm not saying you couldn't, but it's not an easy muscle to access. So the focus for us is more relax the scalenes, mobilize the rib to lengthen the scalenes. But I'm not going in there and massaging the scalenes, and at least that's not what's in the protocol. And I haven't found a lot of success with people trying it. I don't try it, so I mean, it's more from the result of people telling me that, oh, hey, some therapist tried to massage my scalenes and it's killing me.
Just made it worse. You've got this irritated muscle deep inside, and I don't know how much pressure you have to push through everything else to get to the scalene, but it doesn't sound fun if the scalene is irritated.
And I think we're so used to just suck it up and feel the pain and deal with it that I think people let people get away with it. And that's what I was saying earlier about understanding the problem, understanding these concepts, so that when you go see a therapist or somebody and they're massaging your scalenes and it's killing you, you tell them stop. I don't care who you are. I mean, tell me to stop if it's hurting. I'll stop.
So along these lines, Deborah in upstate New York says, is what you just described the single most important exercise that I can use from your program?
If you said first rib mobilization, no. Probably the most important exercise is diaphragmatic breathing exercise. In the program, is an exercise where you're just lying down, meaning your head's supported, your arms are supported, your knees are bent, and you're breathing from the diaphragm. And you're trying to purposely relax the chest. So, which means that if you take a breath from the diaphragm, it cannot be a big breath. When I say a deep breath, we're meaning it's just down here. And the idea is to relax the scalenes. I've had patients who have heard me say that, and they just said, hey, I was just sitting here doing diaphragm breathing, and I think it helped. Just sitting there and doing diaphragmatic breathing, well, there is an exercise in the handout or the program where you're sitting, but that's more of you learn to diaphragm breathe lying down so that you can do it sitting. So you practice it in a sort of a supported, non-postural, focused, relaxed position so you can learn what it means to diaphragm breathe and relax your scalenes. And then when you sit up, you're trying to remember the same thing and just, okay, how does it feel? You have to apply the breathing lying down to your everyday activities, or it won't be meaningful. The idea is not to, the breathing exercises are just to practice breathing. You have to play the music. You got to play the concert. You got to perform. Practice is practice. This is real.
So this parallels with what we were just talking about. It's perfect timing for that question. The rib cage does some of the work of respiration with a series of muscles between each rib. The diaphragm does a lot of the work, and the scalenes are accessory muscles which have to be called into play for some patients with lung disease, but also patients who aren't doing diaphragmatic breathing, correct?
Right. I mean, if you're running, you're going to use your scalenes. Or if you're doing something cardiovascular where you're breathing heavy, or the scalenes are there, it's great that they're there. You need to get air in quick. You got to open up the rib cage. But at sitting on a computer, driving your car, watching TV, you don't need to use your scalenes. Matter of fact, you should not use your scalenes.
But some
and if you
people
have an
do.
irritated nerve in a small space, now you really need to not use them.
Right, but some people they break away from the diaphragmatic breathing and rely too much on these accessory muscles.
Right, it's a pattern. It's a pattern that either developed through habit, or it's a pattern that happens if you're in a slouched position. You've compressed your diaphragm. Right. It's going to be hard to breathe from your diaphragm. You're going to breathe from your upper chest. So right. Your posture. So when I tell people to breathe from your diaphragm, sitting, you have to have an open diaphragm in order to do that.
Just so people know, in case we're not being clear, the diaphragm are these curved muscles at the bottom of the rib cage on each side. Normally, they do a lot of the work of breathing. But if you're sitting, as Steve is pointing out, you have all the abdominal muscles pushed upwards because of the contents of the abdomen. So lying back, I presume, relieves a lot of that pressure and allows you to get that feeling back of default breathing through the diaphragm.
Right. And so I think it's easy at the beginning to learn to do it lying down, but you have to be in a comfortable position. And I mean, I could talk, maybe our next talk will be, I could spend the whole time just talking about that.
That would be good, actually. So here's another question from Silver Plane Crucifix. An addendum to Steve's question, and I presume they're referring back to our first rib mobilization. Is there a product with a ball on the end of the stick that you recommend, or do you have people that make them themselves?
Well, I will tell you, I mean, Peter Edgelow made this, and I don't know if it's kind of, well, it's not unique in the sense that I've seen other products, but it is literally well, here, can I go grab one?
Sure.
I'll be right back.
I want to remind everybody that in 2 weeks we have another talk coming up. I'm going to go look it up right now because we have so many of these. I want to keep track of who our speakers are. So, sorry, I don't have that on our schedule, but I will announce it as soon as we do. This talk is, of course, sponsored by toseducation.org. And December 7th, as we have the banner on the bottom, we have a new patient story. This is another different patient than we've had before, a very interesting and distinct TOS story. And I think this is very appealing to a lot of people to live through the experience of one of our patients who's been through some of those ups and downs. So that'll be a great story. Steve, go ahead. You have the device. Here's the well, they call it a pinky ball or a rib mobilizer. It is literally it's a toy ball you can buy on Amazon. I don't know what stores are open. It's a solid ball, and I make these at home here. I have a drill press. I drill a 1/2-inch hole about halfway in, and I take a wooden dowel. They usually are sold in 36-inch lengths, so I can take one and cut it in half, and it's 18 inches. So that's just glued in there. And
mean, so I make them and I'll sell them at the clinic, but I don't see why you couldn't just make one yourself. I mean, some people go, I'll pay you the $8. It takes me $8 just to drive to a place and find the pieces. But you could make one. And and then this goes up here. Now, obviously you're not sitting or holding it, you're lying down and the ball's going here. And as the stick end is against the wall, and as you breathe in and up and down, the ball is stationary and you're moving towards it or away from it. This is all lying down. And then later on, you lay on the floor and you roll on your back onto it. So it would be similar to people using maybe a tennis ball. The only advantage is that I can take this and I can move it exactly where I want. But I've had plenty of people say, I got a tennis ball or I have a mobilization ball, I'll just use that. But the idea is this is to mobilize the rib. So it's going to be in that space between your spine and your shoulder blade when you're doing the thoracic mobilization. And when you're doing the first rib mobilization, it's on top.
So you're trying to teach the front end of the rib to come downwards. Is that correct?
Well, the back, I guess the back part, I'm more posterior. So if you have that seam on your shirt, it's behind the seam. If you're asking that question.
So I have a question. You brought up musicians. Are there certain types of musicians or certain instruments that seem to induce TOS more than others, in your opinion?
I'm sorry, ask that question again.
Are there certain types of musicians or musicians who play certain instruments that are more predisposed to TOS than other musicians?
I haven't seen enough musicians to say that I've seen a pattern. I would say I would think any of the sort of like breathing type instruments, like woodwinds, sort of things where you have to breathe heavy and a lot, possibly. Although I don't know, I also think that those patients probably have a better understanding of diaphragm breathing than say other people do.
Very good point.
I mean, I've had some patients that have played, again, kind of a woodwind type instrument. But then I have people that play drums and I play guitar. So I don't know if I can't answer, because I think part of the problem is there's still a postural anatomical breathing dysfunction problem. And I mean, hey, I got plenty of patients that all they do is sit at a computer. So and I would imagine that playing an instrument would even be more strenuous. But then if you combine all these other problems together, it could probably be anybody.
So it's obviously not my field, but I wonder about two instruments. One would be a violin, because you have to pinch it between your cheek and your shoulder all the time. The other would be a flautist, who has their head may be straight, but their arms are just held for long periods of time out to one side. Don't know.
Well, that could be, and I'd also wonder if those people have cervical problems too, because it's the side bending, it's the spinal. You're compressing the disc on one side.
For hours
I can imagine that over years of doing that, it's got to be hard on you.
Yeah. We have a follow-up question from Silver Plain Crucifix. Do nasal polyps or postnasal drip that makes nasal breathing more challenging affect the overuse of the accessory breathing muscles? That's a really good question. I think anybody, just interject as I imagine it, when I've had a stuffy nose, I breathe differently. I think I breathe differently.
Yeah, I mean, I think you could still make the argument that you could still learn to diaphragm breathe just using an open mouth. I mean, I know that when you're describing the breathing, you'll tell people it's like any kind of meditation breathing or yoga where you breathe in through your nose, out through your mouth. But then there's people that come in and, hey, I got to, and so I say, well, then you just got to breathe in through your mouth, but you can still diaphragm breathe. So I think the taking the air in is still going to be determined by your intention. And I think breathing through your mouth or not through your nose creates other problems, but we're not talking TOS problems. We're just talking about the problems of a mouth breather compared to a nose breather. But I just can't imagine I can't imagine there's not a consequence, but I also can't imagine that would be the reason you wouldn't get better.
Stephen, one of our regular viewers. Hi, Stephen. He says, have you had experience with patients using postural or scapular stability vests, such as the one made by Dr. Newkirk, the S3 or others? Have you found these to be helpful? And if so, in what ways?
Well, I mean, I'm in the Bay Area here, so Dr. Newkirk is just about an hour up the road. So we certainly see a lot of the same patients, and I think people are positive about the vest. I would just say I like to think of the vest and the EDGELO program as working together, because I don't think that the vest will take care of some of the postural changes, but it does not automatically teach you how to breathe with the diaphragm. And it also there's not the concepts of like no pain, no gain, monitoring your objective symptoms, progressing exercises in a sort of meaningful way. Those aren't really part of the vest itself. I mean, Dr. Newkirk would give you advice on what to do or not to do. I certainly believe that. But I think it's like a lot of things, you tell people, hey, we're going to work on diaphragm breathing. We're going to work on, I'm oversimplifying again, but on your posture. And then people go, yeah, but I just can't do it. I just keep, and I get working on something and I just sort of collapse. And then you're looking for sort of these external devices to kind of help just remind the person that, hey, this is going to help me maintain that posture. So I think there are good things. I just feel like obviously they're kind of like a piece of the puzzle. I like to think that the INVEST program is also a piece, and it's an important piece. So I think using them together would probably be the best, using all these things together. I think for some people, they need a multi-directional
Absolutely.
approach.
So if it's just a passive device and patients rely on the vest to do the work for them, you feel it's not as effective as if it's a reminder and the patient learns better posture by having the vest constantly remind them.
Yeah, I mean, but you're still, the idea is to open up the space, and the idea is if that's, like I said, that space is open, then that nerve can calm down over time. So, I mean, it definitely has a purpose that's very meaningful. I just think it's, and hey, it's like a lot of things. I mean, there might be people that maybe the vest is the most important part, and maybe that's enough. And then there's other people where, hey, maybe the breathing exercises or the EDGELO program is enough. You don't need the vest. Simpler the better. But a lot of these things aren't simple.
TOS patients are very heterogeneous. They have different mechanisms and different reactions, different responses. So, making one rule or generalization obviously is a dangerous thing for us.
Right.
A follow-up question from 330K Dog. Do you incorporate non-invest exercises based on other comorbidities the patient may have, such as shoulder injury or pec minor compression?
Yes, I mean, so I'll see patients and they'll have back injury, they'll have cervical disc problem, they might have a rotator cuff injury. And so I think the challenge is kind of trying to determine like how much of a percentage or how much the TOS is playing in their overall injury. So for some patients, you know, if I think, hey, it could be more cervical, then you're going to be treating the cervical spine probably in a different way than the invest exercises or the Edgelil program. Although I would still say that the concepts of posture seem to like address so many issues. Low back, I mean, if you have a low back disc problem and if you follow the McKenzie program, posture is important. It's critical. If you have a cervical issue, posture is critical. So, I mean, there's never a point that you're totally off. You're doing something totally different. The person had a rotator cuff injury though, and you got to be careful if you give them some rotator cuff exercises that could irritate their thoracic outlet. So if you have more than one thing going on, you have to treat the thing that gives you the most gain. So you're probably better off shoulder injury, thoracic outlet. Let's get the thoracic outlet under control. Then we can deal with the shoulder later.
So part of 330K Dog's question, which I find interesting, he refers to pec minor compression. How much have you found pec minor involved in your patients, and do you treat it at all?
I mean, the pec minor is, a lot of patients is sensitive, and there are times you can kind of compress there and they might feel some pain. I would still say it's probably secondary, but there are exercises that we use to kind of open up the pec minor area. But you're still, again, those concepts are all the same. So everything I talked about today, would apply to any kind of pec minor compression. And I don't know about you, Scott, but I just feel like it's probably, if they have pec minor compression, they probably have something else going on.
Thank you for asking. From my review of the literature and my experience, which is not small, I think the pec minor syndrome is misunderstood. 330K Dog obviously understands it from the literature because he talked about pec minor compression. But I'd like to add in, I'm pretty comfortable with this, it's rare to get compression behind the pec minor, what we call the retropectoralis space. It's actually been shown that patients who are normal, no symptoms, normal people, versus TOS patients, if you do MRIs, the people who have no symptoms get more narrowing of that space than TOS patients do when you raise their arms. So I believe what's happening is the pec minor is out of balance. I always say this, there are 17 muscles that attach to your shoulder blade. The pec minor is one of them. If these get out of balance, they can shift the position of the shoulder blade and then shift the position of the collarbone quite directly. So I think working on pec minor, I don't think it causes compression. I think it changes the balance of the shoulder. I'll also say that a guy named Jerry Lord back in 1950 did the first pec minor tenotomy where he just snipped it, and he had good results for TOS patients. Peter Edgelil was the first one who mentioned it to me years ago. He told me about a doctor he had forgotten the name of in Sweden who had done this maybe even earlier than Jerry Lord and had good results. So we do know that a pec minor tenotomy or a block like lidocaine or Botox into the pec minor in some patients can help. But I do not believe it's because the nerves are compressed back there. So that's a really good question with a lot of levels to it, and I appreciate that. Thank you for the good question. Here's another follow-up from Silver Plane Crucifix, Steve. I found it interesting, Feldenkrais walking awareness is given as the walk progress for the INVEST program. I was wondering if you could discuss what you like about that.
I mean, first of all, walking is part of the INVEST program, and I think part of it is, as we need to move. I mean, a lot of these conditions, people are getting thoracic outlet, either irritating it or sort of stimulating it or causing it is from these static positions in front of a computer, repetitive work. I mean, obviously it can be, maybe they have some anomalies, but you combine that with these sitting postures and repetitive movements. And so, I mean, walking obviously is just the opposite of that. So you're up, you're moving, you might even be, probably because of a more erect posture, you might even be breathing better because you're being more, you're more active. And then, of course, the Feldenkrais part has always been about like awareness when you're moving and feeling or learning how to move without, causing pain. So I think this idea of this Feldenkrais movement awareness while you're walking sort of fits with the INVEST program. I know Peter was starting to get, before he got sick, I'd get very excited about kind of including some Feldenkrais type concepts into the INVEST program. I'm not as, I mean, I totally support that. I'm just not a Feldenkrais expert. So I would say that I'm probably, would be hard for me to sort of give you a Feldenkrais explanation as to like why something is, or how they would approach it directly. But
Because
I still think the
walking,
idea of,
Steve, because walking will encourage the abdominal organs to drop. Does that encourage diaphragmatic breathing, in your opinion?
I think so, and I think also the fact that I said, I mean, I think it's harder to maintain a straight posture when you're sitting. It's just, we just tend to kind of collapse. I think when you're standing, now, don't get me wrong, we see people standing, and I'll watch people. My wife's a PT too, so we're sitting there on the park bench watching people walk by, and we're like, oh my God, look at that. I mean, that person must really be hurting. I mean, you can tell, they're either leading with the way they're walking and shuffling. And so there's still problems with walking. Although I don't know if I would say it's a thoracic outlet problem or probably more like knee, hip, and low back dysfunction. But
Well, clearly,
if
when
things
people
are
have,
flared up enough, I mean, walking can flare it up, but I just think it's more because of the swinging of the arms and the bouncing. And I don't know if I think it's just it's so sensitive that just even walking itself it's not the walking, it's probably just the weight bearing and the movement.
so to go backwards a bit, you brought this up. If people have TOS, they tend to guard by bringing their shoulders and their head forward. They're going to change their center of gravity, right?
Sure.
So they'll have secondary changes in their lumbar spine and their walking.
And who knows if, or maybe it was the dysfunction in the spine and the knees and hips that created this poor posture too. I mean, a lot of people come. It depends when people come in, and the questions are always like, well, do you have neck or back pain? And the person says, well, I've had back pain for a long time. It's I'm just dealing with it. It's not even related. And I'm thinking, but the way you sit is going to affect the way the position of your head and shoulders. So if you've had back pain, it's going to affect your posture. And if you're on that edge of, a little bit less space is going to create problems. That loss of that postural, that low back pain can lead to another dysfunction or another compensation. And it tends to sort of just develop over years. I mean, there's very few people, and occasionally there is somebody who just says, I woke up with thoracic outlet. It's more like, it's a series of things that have happened over years.
Jonathan, hi, Jonathan. Jonathan in San Diego says, is there a physical therapist in my area that uses the Edgelow system?
I don't know. I hate to say that, but and that's one of those kind of questions people ask me. I have a patient I'm seeing right now that's from San Diego, so I like to think that if you could have found somebody closer, he would have done that. It's just that I think the problem is it's been probably 10 years since Peter was in the clinic. And of course, he passed away 3 years ago, or over 3 years ago. So it was 10 years before he was in the clinic, and it's probably even many years before that he actually taught. So I think that, I'm not saying many, but it's more than 10 years. Because he's having some problems even 10 years ago. So I think the problem is that the EdgeLo program, or teaching the program, is just sort of, it just hasn't happened for so long. And there are still people that know him, and there's people in the Bay Area because that's where he's from. But if you talk to a new grad, and I mean even 10 years ago, who's Peter EdgeLo? And they're going like, I don't know. They don't even know who he is. It's like hard to believe, but it's true.
I was just about to ask you if people want to reach out to you, Steve, for more about the EdgeLo technique and the INVEST program, and maybe to get appointments with you. And I see a banner at the bottom of our screen already.
Oh,
So if people do want to reach out, would you prefer them to reach out to my website and I can put them in touch with you? What do you
sure.
prefer?
I think that'd be a great way to do it.
Okay.
And like I said probably earlier, I mean, I know some people have been contacting me. If I have a number of patients in the last several months that have local patients that have, and even people. I have a couple patients from Southern California that have reached out to me, and we do telehealth. And hey, if their insurance covers it, we'll go through the clinic, and we'll schedule a time when I'm there. If people are out of town, they don't have insurance, we can do something privately. But I'd say reach out first and find out how it's going to work, and then we'll make it work.
And I can vouch that Steve is just as nice a guy, if not more so in person, than he is on our videos. Every patient I know really, really digs you, really thinks you do great work, and thinks you're just the nicest man in the world. So,
Peter was the
compared to
nicest
me, of
man in
course,
the world.
second nicest, but
Yeah, well, thank you.
I wanted to ask you a question that I had before, which is, you mentioned autonomic symptoms when you were talking about objective versus subjective. So autonomic signs and symptoms, disturbance of blood flow, like temperature changes, color changes. Do you see those in certain types of patients? How often do you see that as part of TOS?
I see it pretty often. I mean, there's now hand temperature is not always part of it, but I would say more often than not, I'll see a hand temperature change. Again, some color changes, and so I do see that, and it's pretty common. And what's nice is not the right word, but it's good to have something to measure, because you can literally see somebody do an exercise, the breathing exercise, and their hand temperature can change 10 degrees in 5 minutes. It's almost. Sometimes the people are. I have to write it down. So what I'll do is I'll measure the hand temperature, and I'll write it down. Okay, it's 78 and 82. And then they're doing their exercises, and I write it down on my whiteboard, because then I measure it after the breathing, and I write down what that number is. And then because it's not something in people's, it's not on the radar kind of thing. And I say, wait, your hand went from 78 to 89. And it's like, oh, okay, yeah, I guess. Now, for some people are excited, and some people are like, it's a trick. But it's that window into sort of seeing what direction you're going into.
Yeah.
I'm convinced that you'll see those changes quicker than you will feel those subjective pain, numbness, and tingling.
Wow.
So my story is you're going to look better before you feel better.
So Wadislaw Ellis, who's been a TOS expert for years, really nice, really smart man, lives up in Grass Valley, California. I don't know if he's still seeing a lot of TOS patients. He published a paper in 2003 out of UCSF, University of California, San Francisco, with Dr. Cheng. And during surgery, what they did, Steve, is they measure the temperature of the hand. And then when the surgeon would do a neurolysis or remove an anterior scalene or a scalene minimus, they would measure, did the temperature of the hand change? And they found significant changes, removing these muscles, freeing up the nerves, removing the scar around the nerves. It's a very interesting paper. So objective support, measured support for what you're saying.
And I mean, who even knows? I mean, I've had patients that come in and it's sort of, my hands have always been cold. I'm just theorizing, but I mean, those could have been symptoms that were showing up way before the subjective symptoms came. I mean, you're speculating now, but I think
I
it's
can
a progression.
There's a paper from 1910. I think it's written by Todd, and obviously not very recent, but he did dissections in human cadavers and found that for certain patients, all the autonomic nerve fibers within a nerve bundle were clustered at the edge where they were riding over the first rib. His theory was that some patients show up with predominant autonomic problems because they just have this anatomic variation where all the autonomic fibers are just bunched together in a vulnerable position.
Huh. Interesting.
Okay, Scott.
Fascinating to think about.
Results. I'll send them to your iPhone.
Siri is listening to me and trying to pull up this reference for me.
You can also try spelling it.
All right, let me cut that off. Siri shouldn't listen to me. So another question from Silver Plane Crucifix. I wish I had a first name. I'm not being rude. I don't know what it is. Does the different injury mechanism, like a single trauma versus a computer overuse injury that is more progressive, affect the treatment protocol or outcome for TOS? It's a great question. Thank you.
I don't think that the treatment protocol would be different, except if there was a trauma. You're again looking at, would there be other sources of pain? Let's say, I mean, a car accident, for example, and I have patients that call me and I've been in a car accident and I think I'm developing TOS, and so you're looking at the cervical spine, the shoulder, it may be that there are other factors besides just the TOS that you have to address. And also, I think there's probably a more there's going to be more trauma to the nerve. I think to the vascular, to the brachial plexus. And I think that's, that can be a problem because it can be trauma to the nerve. I mean, I'm thinking of some of the patients I've seen that maybe they fell and grabbed something and they got a traction injury.
Right.
And that's a bit more serious. I mean, there can be some actual damage to the nerve itself. Whereas compared to a computer person, where I think there's just this gradual progression of symptoms. And so you're hoping that maybe by changing postural awareness, breathing patterns, that they can improve. The question is, though, a person has trauma, do they really have a problem with their thoracic outlet before this, or is it just a tractioning injury? And I guess in that case, I'd probably just call it a brachial plexus injury, not necessarily a thoracic outlet.
And yet there are patients, the classic whiplash, right, where the head goes two different directions, where you can easily conject that the scalenes stabilize by squeezing down and then get micro tears.
Right.
It's actually been shown in studies that the scalene muscles change after a traumatic event. So
Sure.
Those patients would have a TOS type syndrome without a direct injury of the brachial plexus.
Okay.
The depth of this question, I really like this, is that number one, you talked before, Steve, about the time of how much time is involved to get better. So here you have a very short injury, one injury, versus a person who's been non-ergonomic at a computer workstation for a couple years or more. So that's part of the question. Then the other part is there really a different mechanism, which you just kind of brought up? So do you think that a very short time frame, let's say the person comes to see you within a week or two of a motor vehicle accident, do you find that you have a better chance of success than somebody who's let's say 5 years at a computer workstation?
Maybe. I just think it, I guess it depends on how severe things are. I mean, if we're going to talk, I talked earlier about like what kind of injuries seem to be sort of hard to deal with. And of course I said, thoracic outlet, but motor vehicle accidents are hard to deal with. I mean, there's multiple trauma besides like maybe scaling, tearing. There might be sort of ligament issues, disc issues. I mean, I think motor vehicle accidents are pretty devastating to a lot of people. And I've seen people that, it takes a long time to get better. And a lot of times, and part of that too, it's just the same issue that people have with thoracic outlet is, a lot of people think, oh, thoracic outlet, does it really exist? Is it really there? You get a motor vehicle accident, it's like, yeah, so what? People people don't have a lot of sympathy for, because I think they view car accident patients as being sort of like exaggerating, because, and especially when a person has an injury and they walk away from the car accident feeling kind of not so bad. I mean, obviously there are cases where they're taken away in an ambulance, and then all of a sudden a day or two later they start having pain and everybody's like, well, you were fine. Now you're just looking for a paycheck.
Great point. It's a classic story. I've seen it a million times.
And in reality, there was a real injury. You were probably just on adrenaline. You were just, or it just took a few days or a week before the symptoms really kicked in. And I totally believe it. It happens all the time. And I don't think people are out there just for a paycheck or a check or settlement. I mean, so I think there's a lot of problems. Car accident people get the same kind of disrespect a lot of times as TOS patients do.
Whiplash is viewed with some pejorative nature.
Sure, it's kind of like it's kind of seen as a scam, and I'm sure in some cases it is, but there probably was never a whiplash. If it's a scam, it's just a scam. A real whiplash is a real serious problem.
It's part of what I call the CSI syndrome. We have so many tests for things that if you have a disease where you don't have a test, people kind of shrug their shoulders. Well, we'd have a test if it were real, but that's not the case. There's always new tests because we're understanding things over time. And that's very interesting with TOS, how it got this unfortunate non-scientific layer on it, which is, complete BS. It's a real disease. For any of our viewers, I don't have to tell them, but it's absolutely a real disease. And for doctors to blow it off because they don't want to learn about it is most unfortunate for those patients. My little soapbox, sorry.
Yeah.
Let me look at my list and see if I have any more. I know I've asked you a lot of questions. I really appreciate you being a good sport about stuff. Yeah, I think I've asked all the questions that I had from listening to your talk. So people, again, who are viewing, you can reach out to me through tosmri.com, and I'll gladly put you in touch with Steve. toseducation.org does all these great educational things. And again, thanks to them because we get these great speakers, and we have hopefully been slowly spreading awareness of TOS and helping people understand it on a layperson level. Although most of the patients I talk to don't sound like lay people. They learn a lot on their own, more than a lot of docs. So that's an encouraging sign. And I want to thank everybody who's viewed and asked questions. We really appreciate that. So again, I'm Scott Worden, Dr. Scott Worden, the TOS guy. We welcome any questions on our website, any connections you want with doctors, and any knowledge or resources about TOS, just reach out to us. We're always happy to hear from you. Steve, anything you want to say to our viewers?
No, again, thank you again. I felt privileged to have worked with Peter and to be able to have some knowledge to help patients with thoracic outlet, and also I'm thrilled to have kind of met Scott and other people in the group who have the same passion. So people are in this to help. They truly
Steve,
are. They're not in it to make the money, because they're in it because we realize that people are underserved, and if I can do anything to help, I mean, it's what I do this for.
I will say, Steve, that a lot of the people that I've met who really specialize in TOS, yourself included, just tend to be really giving, nice, caring people. Like Peter, who is a prince of a man. I miss him. And so we're lucky to work in this field because we meet good people. I'm going to actually test how nice you are right now because we have one more question. Would you be willing to field one more?
Sure. Yeah, go ahead.
Okay.
What's
So Silver Plane Crucifix says, earlier you were talking about postural correction being affected by pain further down the kinetic chain. Do you recommend lower extremity strengthening exercises to help correct posture? This is Johnny from New York. Okay. I spoke with Johnny earlier today. He's one of these typical lay people who knows way more about TOS than any person should. He has very sophisticated questions. So Johnny, I didn't know this was you, that this was your screen name, but that's a good question. So Steve, do you recommend lower extremity strengthening exercises to help correct posture?
I mean, I'm probably looking more at kind of pelvic area, starting there. I mean, especially since, I think when we're sitting, it's the pelvic position that sort of begins the chain moving up when you're sitting. So it would be more kind of pelvic control. People say core, and I mean, there are times there is some core exercises in the program, although again, there's core can mean anything. So if you're doing a core exercise, you have to make sure you're not kind of engaging the scalenes or activating the neck too much. So I think, if you give people, I still say, all this stuff like core exercising, lower extremity strength. I mean, I'm still saying is that the problem's here. We have to learn how to control this area first, and then as this gets kind of under control, then you can kind of broaden your focus. And sometimes when people are looking for exercises, because people want to get back to the gym, they want to do some strengthening. And I tell them, just kind of hold off on the upper body stuff for right now. We might start with the lower extremity as being a way to sort of start exercising, because there's probably safer ways to do that before as opposed to doing stuff upper body. But I guess so. If you're looking, it depends. I guess what you're defining as lower extremity. I mean, if you're saying quad, hamstrings, calf, I mean, maybe thinking glutes, hip exercises. Yeah, that's a good idea. But nothing. You can't flare anything up. It has to be. It depends where you're at. That's why it's a spectrum. Some people can start things sooner. Some people have to wait longer. It's just how they react to an exercise that kind of determines like what you add and when you add it.
So you said you focus on the pelvis. Is that because everything above the pelvis, the spine on up?
Right. And and if you're thinking about posture, it has to be, again, and it's when you're sitting, it has to be pelvic position first, then low back, then thoracic ribs, and then shoulder and the neck. That's the postural part. We start from the bottom up, although when you're doing the diaphragmatic breathing exercise, there is a pelvic mobility movement exercise, but that's more for kind of movement, blood flow, and to kind of get spinal nervous system mobility centrally. So we're looking at it as a movement exercise more than probably like a strengthening exercise. Although there is, every time you exhale, you use you're using your core muscles and your intercostals.
Thanks, Steve. Johnny, thanks for the great question. I hope that Steve's detailed answer was helpful. Thanks, Steve. Again, this is Dr. Scott Worden, the TOS guy, saying thank you to everybody who attended. Help spread the word. Follow us on social media. We are TOS MRI on Instagram, Facebook, YouTube, and Twitter, and we'll be expanding our social media over time. We hope to spur discussion and to let all the TOS patients out there who may not know they have the disease find the right specialists. Thanks again for your time, Steve. Thanks to all our viewers. And
Thank
we'll
you,
see you
everybody.
December 7th.
Thanks.